Welcome to the Neuroveda podcast for complex health. We feature guests who dive deeply into the nuances of medicine with the goal of inspiring you to persistently heal in the face of inevitable challenge across the lifespan. This is about ancient and cutting-edge understandings of diseases and treatments, just as much as it is about food, lifestyle, nature, culture, and politics. I'm Jillian Ehrlich, family nurse practitioner, certified in Ayurveda and functional medicine, coming to you from our clinic on the shores of Lake Union, Neuroveda Health, Seattle, Washington. And we have a really exciting guest. I say exciting. She is a clinician at our clinic, which I'm thrilled about because this gal is brilliant. And you're going to be hearing a lot from her in the next couple of years as she grows her practice here. And today our topic is integrative oncology. So Dr. Julianna Giles, welcome. Dr. Giles is a naturopathic physician with a master's in Ayurveda who specializes in integrative oncology, endocrinology, chronic infections, medical cannabis, entheogens, and psychoneuroimmunology. After graduation from Bastyr University, she completed 4 years of residency training in integrative oncology and is in process for FAB and licensing, which is the naturopathic oncology program. She's a core lecturer for the Academy of Cannabis Science and lead formulator for Polite and Lumina, both medical cannabis companies. While at the University of Wisconsin-Madison, she researched medicinal mushrooms and medical cannabis as adjunctive cancer therapies, as well as the neurological effects of mindfulness at the Wisconsin Institute of Sleep and Consciousness. With over 1,008, a very spiritual number, with over 1,008 hours of yoga training, Dr. Giles is certified in Ayurveda yoga therapy, prana flow, and Kundalini yoga. In her free time, she practices yoga daily, is passionate about plant-based cooking, and loves exploring the wild Pacific Northwest, knows a shit ton, and talks quickly. So put on your seatbelt. Dr. Giles, welcome. We're so happy to have you.
Thank you, Jillian. That's a perfect intro, especially the last part. I do have a lot of information and I go fast, so slow me down if you need to.
I will. I'll be there. We were just talking. I'll just reveal all of our secrets here right in the beginning. That's how I roll. It's like I'm going to put a finger up if it's like slow down. So, but there's a lot to cover. Cancer is a huge topic, and cancer happens. It's one of these very in some ways egalitarian conditions where cancer happens across the age spectrum, across the socioeconomic class spectrum, across culture, across, all sorts of different types of people, levels of poverty. People do get cancer, although we always need that caveat where in areas where there is more environmental pollution, we do see more cancer. So let's start out broad and then kind of dial down, like, what is cancer? There's so many types of cancer. What is cancer? How can we think about all these different types? And where do we start?
Yeah, that's a really good question. It reminds me of, I think it's called The Emperor of All Maladies. There's a book, and then it's essentially a cellular biologist goes into the first cancer cell, because when we think of cancer, we think of a tumor usually, or a leukemia or a lymphoma. And that's once the cells have really replicated out of control. So at that point, it's way more than just one cell, but there has to be the initial cell that, due to mutations, genetic factors, environmental factors, it mutates and it becomes the normal cell cycle has stops. Like, check, did we do all these things? Yep, all these things are done. Okay, keep going, check. And something goes awry where those check marks, or one of those check marks, no longer is check. And so the cell starts to replicate out of control. That's step one. Step two is these cells generally mutate in a way that they can evade our immune system. So normally, if one of those cells starts to replicate, the immune system knows these are not right. These cells are not like us. They're not normal cells. We have to come in and clean that up and kill those cells. Or the cell itself has programmed cell death called apoptosis. So it will actually, again, if it goes to one of those checks and something's wrong, it essentially implodes and deconstructs. But all of those elements have to be not working, have to be impaired in some way. And again, cancer cells mutate in such a way that they are not trying, because they're not thinking like we are. But of course, in Ayurveda, we think of all cells as intelligent, all cells having consciousness. And you can kind of think of it as this cell has lost its memory or its identity, and it no longer knows who it is, what its function is. And at that point, again, mutates so that the immune system also can't catch it. And once that happens, we have uncontrolled cell growth of multiple cells. And then the cells keep dividing and dividing and dividing. And that's what we call cancer. If it's just a tiny little solid tumor, normally you can just get it removed and that's it. But once it gets big enough or it breaches into our bloodstream or our lymphatics, then it can move anywhere in the body that has receptors that it can home at, that it can latch onto and take place in. So that would be a metastatic disease or stage 4 cancer. And it's a very long process. It's not like this happens overnight. This happens in a matter of usually years, sometimes decades, at least months, even with the most aggressive forms. So that's essentially what cancer is in a nutshell.
Okay. And so how do we think about all of the different cancers, colon cancer, lung cancer, brain cancer, leukemia, lymphoma? How do we think about all those cancers? Are there ways that they kind of fall into any type of categorization or groupings?
Yeah, another really good question. So the kind of the first differentiation is it a liquid tumor, aka a leukemia or a lymphoma, or is it a solid mass, a solid tumor, which is most of the cancers that we think of? Anytime there's a growth, that's what we call a solid tumor. So that's kind of the first differentiation. Then you have, it actually goes back to the embryology, so the origin of the cell type. We have endoderm, mesoderm, and ectoderm as our embryonic tissue types. And that's kind of the path that cancers fall into. So mesoderm origin would be a sarcoma, and that's a cancer of the connective tissues, essentially. So the things that hold us together, muscles, bones, it could be ligaments or tendons. We don't see that very often. Usually it's muscle or bone of some kind. And then there's the ectoderm would actually be things like neurological tumors. So like a brain tumor, like a glioblastoma or something else. Could also be neuroendocrine, but generally neuroendocrine and skin cancers as well. And then that endoderm, this is where most of the cancers that we see are originating, because they're carcinomas. So you'll hear that a lot, like breast carcinoma or adenocarcinoma of the colon or adenocarcinoma of the pancreas. That all means adeno just means it's glandular, and a carcinoma just means it's a cancer that originated in one of the linings or of something, a ductal tissue or your GI tract, something that's more internal, but not kind of when we think of it, the deepest layer, but really it's something that's generally interacting with the outside world, like our GI tube, or like the breast, ductwork, things like that. So that's a carcinoma, or an adenocarcinoma, again, is just a glandular component, but those two are pretty overlapping.
Okay. So that's how we can think of like different types of cancers. And we're understanding that cancer is essentially a loss of intelligence of the cells. Can you talk a little bit more about the Ayurvedic perspective of cancer?
Absolutely. So in Ayurveda, we think of it as cancer is one of the most complex of the diseases or illness states, because every dosha is involved in a cancer. And there's a loss of prana, tejas, and ojas in this. So the immune system is depleted. There's too much inflammation, too much heat, and there's a loss of awareness of what am I and what's my function in this larger system. So that's the prana, tejas, ojas, or ojas, tejas, prana. And then from on the larger scale, with the doshas, you have generally, if it's a solid tumor, that's thought of as kapha dosha. It's a growth. It's something that's stagnant, not moving, growing. It's just kind of this like a rock or something. So very earthy. As cancer progresses, all cancer has inflammation around that tumor. The immune system is trying and failing, but trying to attach and get this thing out of there. And that causes inflammation. And then that inflammation causes systemic inflammation because the immune cells are talking all over. And so that's where Pitta dosha is involved with the inflammation. And then anytime cancer spreads, that's Vata dosha. So Vata is the mover and the shaker. It's what moves anything throughout the body. So if you started with a tumor in your ovary and now there's a tumor in your lung, the only dosha that could have done that is Vata dosha. So by the time cancer is in stage 3 or 4 or advanced cancer, you already know all the doshas are involved. If it's just a primary tumor and not, it hasn't spread, Vata may or may not be involved. It depends. But definitely with metastatic illness, that's all doshas are involved.
Okay. And so what does a typical conventional care look like to treat cancers? What are our options, like just kind of by class or by category, treatments for cancer?
Yeah. So something that I learned when I was in residency that really struck me or impacted me is that the only cure for cancer is surgery. If it's a solid tumor, the only way to actually get rid of the cancer is to get it cut out. And the only way that's going to be curative is if somebody gets clear margins, it has not gone into the lymphatics nor the blood vessels, the vasculature, and it has not begun to spread to other areas of the body. At that point, it's a total cure. It's gone. Now, when it has spread, then surgery really isn't even indicated, because anytime you open up a body, all these growth factors have to come in to heal the wounds from the surgery, and that's just going to cause rapid progression of whatever cancer is remaining. So once a person has metastatic disease, it's very rare that they will operate for that reason. But really, in those early stages, if you can get it cut out with clear margins, you don't have cancer anymore. Now, we still want to work on the foundations. Why did that little growth get there? What's contributing to that? How can we prevent this from happening again? Because it already happened. But at that point, it's gone. Now, once it has, maybe it hasn't spread, but it looks like maybe a little bit got into the lymphatics or into the vasculature. At that point, they'll generally irradiate, do radiation therapy, external beam radiation, gamma knife, lots of different ways to do it, but neutron, lots of different types of radiation, but they'll irradiate that area to make sure that no residual cells in that area are going to continue to grow. And so that's often surgery is paired with radiation, but not always. But if it's gone into or if there's a positive lymph node, something like that, then they'll do radiation. Or there's a lot of radiation also in the brain if there's a primary brain tumor, because it's a lot more difficult to operate, of course, in the brain. And so it's a lot easier to do radiation. So that's one of the mainstays of therapy for various, like glioblastoma, for example. And then there's also, of course, the most famous, I think, is chemotherapy. Everybody knows about chemotherapy. Everybody hates chemotherapy, but there's a time and a place for chemotherapy. But chemotherapy can be used either before or after surgery. Like if they want to shrink it to make it more resectable, they might do chemotherapy first, shrink it, then take it out. Or again, if it seems like the margins weren't clear, or if it has gone into the lymph nodes, or if it's progressed a little bit farther, or if it's a cancer type that responds particularly well to a certain chemo cocktail, they might do the chemotherapy afterwards, after surgery. And just kind of, again, it's kind of like carpet bombing, hoping to get everything that might be hiding out gone.
And then with chemotherapy, like, what is chemotherapy? We can all picture kind of like either shots or injections or IVs or oral pills, but what are those chemicals doing?
It's a really good question. Also, they all have different mechanisms. So they all do different things, but essentially the main thing they do is they're targeting various again, that cell cycle with the stops, et cetera. It's targeting different areas of that cell cycle to slow down or to completely stop cellular replication. So it's not really it can kill some cancer cells, but mostly the idea is stop the growth, and if it stops the growth, then they do eventually die. The immune system cleans them up. And so it's trying to kind of halt things there. But in doing so, it can be various mechanisms that will stop that cell cycle, but essentially it's targeting replication because cancer cells are spiraling out of control, replicating way faster than our normal cells. And this is actually why people lose their hair, or why they get a lot of digestive upset, nausea, vomiting, skin lesions, things like that, because those are also cells that turn over very quickly. And so the chemotherapy doesn't care if it's a cancer cell or not. It's just targeting that replication. So any cells that replicate rapidly are going to be affected, obviously temporarily. They'll bounce back when it's done. But the immune system still has to do a lot of work cleaning up all that, what we call necrosis at that point, kind of like yucky, not programmed clean cell death, but messy cell death, like kind of a murder scene. Then the immune system has to go in and play recon and clean things up. But unfortunately, the immune system is also dramatically affected by chemotherapy because those cells also turn over very rapidly. So everybody who's on chemotherapy essentially is immunocompromised, again, temporarily, but for about a year afterwards, their whites are low, they become anemic, things like that. So it's a delicate balance of trying to kill enough cancer cells or stop the growth of enough cancer cells without too much collateral damage on our own healthy cells. And it can be a tightrope for sure.
So here's kind of one really interesting thing to kind of discuss. There is one way to kind of make chemotherapy easier, right? Or more tolerant to the body. And can you talk a little bit about that?
Yeah, absolutely. So the other sort of mechanism other than the targeting the cell death is all chemotherapy is pro-oxidative. It's causing oxidative stress and oxidative damage in the mitochondria in particular of those cancer cells, because cancer cells' mitochondria are already really weird and wonky. Their cellular metabolism is not like healthy cells. And so they have a lot lower threshold for oxidative stress. They get very little stress can throw them into death because they're just inherently unstable. That's also where the Vata dosha comes in. They're just unstable. So one thing that I like to use alongside many types of chemotherapy, not all, but many, and we have huge amounts of data on this, is high dose IV vitamin C. High dose, everybody thinks, oh, vitamin C is an antioxidant. Yes, it is. But when you get above 20 grams into the 25 gram to 75 gram, even 100 gram range, and if people don't know what a normal dose is, about 500 milligrams is a normal dose of vitamin C, maybe once to twice a day. And that's still a pretty high dose. So we're talking, that's one gram, basically. 1,000 milligrams is a gram. And so we're talking up to whatever, 100 of those, 100 times that. So really high dose, or 50. 50 is probably the most common, but we have a whole algorithm and how we decide what the dose is. But it's also pro-oxidative at that level. And what it does is it increases hydrogen peroxide in cells that do not have a particular enzyme called catalase. So to any of our healthy cells, no big deal. A little hydrogen peroxide, catalase comes in, breaks it into water, basically, changes it into water. It's no big deal. Our cells know how to handle it. But cancer cells don't. They don't have that enzyme. They don't have catalase and other superoxide dismutase, other enzymes that help to reduce the free radical burden. And so when they come into contact with these high doses of vitamin C, they essentially explode, they lyse, they die. The other interesting thing about high dose IV vitamin C is that it can actually target cancer stem cells, which chemotherapy does not, because the stem cells are a reserve of stem cells, cancer stem cells, is very likely why people can have recurrences like 10 to 20 years after they had an original cancer diagnosis. You know, they're in remission, everything's fine, they're 10 years out, oh, you know, it's way in their past, 15 years out, and then they have a cough or something. Go get a chest x-ray and lungs are filled with tumors that came from the breast from 20 years ago. So and it has to come from stem cells. So for some reason, there was some signal that caused that stem cell that was laying dormant to wake back up. We don't know. We don't understand this. It's definitely being researched, but we don't really understand the cellular biology of this. But it's fascinating, because if you can target the stem cells and get rid of the stem cells, then a person will not have recurrence, or will be very unlikely to have recurrence.
So what's the reservoir for those stem cells? Like, where do they hang?
We don't know. That's what's fascinating. Yeah, that's what's fascinating. That's been the ongoing. I used to have conversations all the time with my attending, like, where are they? And why do they turn on? What's causing that? You know, but how do we figure that out? They can do, in a research setting, they can do probes, and they use vitamin C and NAD as the probes to find the stem cells. So they know how to target. Some antibiotics will also target these stem cells, like azithromycin, doxycycline. So it's pretty interesting. We know how to find them, but we don't know where they go or why they're there. Probably somewhere in the blood or the bone marrow, or, you know, hanging out, but we just don't know how long they can hang out, what turns them on. It's all very, very mysterious at this point. And I think probably a lot of research will go into that in the next 10 or 20 years, because that's really how you can cure cancer if you can't cut it out.
Fascinating. Okay, so we do IV. I'm saying this like a question. I know the answer, but just to say, we do IV, high dose IV vitamin C at the clinic at Neuroveda Health and here in Seattle.
Yes, we do. Yes, we do. And anybody who wants an IV will generally see me, and I will clear them. And we have some you have to do some labs before and make sure everything's safe. But honestly, it's even though, yes, it's a pro-oxidative treatment, I have seen countless times that people are so much easier, or have such an easier time handling the chemotherapy when they have the high dose vitamin C, ideally, you know, surrounding their treatments. And it's totally compatible, because again, it's not, I get this all the time from oncologists. You can't have vitamin C, you're on chemotherapy. I'm like, no, this is high dose vitamin C. And I have, like, you know, 30 citations or something, like, this is the evidence, this is why we're doing it. And so it doesn't antidote, it just augments actually the effects of chemotherapy, especially carboplatin and Taxol, which is generally used for gynecologic cancers. Like, we have the most data for that kind, but also for FOLFIRI, for FOLFIRINOX, capecitabine. I mean, there's plenty of others that have a decent amount of evidence as well. If there's no evidence, I generally won't use it if they're on chemotherapy, but if there is evidence, obviously I will. And again, the treatment effect aside, people just feel better. They have more energy. They feel, they have less nausea. They're just able to tolerate the whole experience. And I've had patients actually say, you know, I had to do chemo again, and I just was too tired to do the IV infusions. And oh my God, I barely made it through. Like, last time seemed so easy. When I did it, I couldn't believe how much harder it was, you know, like, and these are people obviously who've had multiple treatments. And so I've just heard that enough that I really can attest to the fact that it does help. It helps a lot of people, and it does improve treatment effect, and it does target the stem cells, which is huge.
Okay. And so are there particular recommendations for when to do the vitamin C around various treatments around chemotherapy?
Yeah, generally not same day, but like day before or day after. Generally, I'll have people kind of preload the day before, and then maybe a few days after. So it depends on their chemo cycle. You know, if they're doing just one infusion every 3 weeks, then I would say at least twice a week, the week of their infusion, if they're able. Sometimes people are feeling pretty crummy and can't. So then for sure the week before and the week afterwards, but at least one the week of their treatment. But generally I'll do 2 a week for a series, depending on how often they're doing chemotherapy. And some people do metronomic or low dose chemotherapy weekly. And so at that point, you can do it on the same day. It's not something I generally have people do, but you can. I think it works a little bit better the day before or after. So if they're doing metronomic chemotherapy weekly, then at least once a week, if not twice.
Okay. Gotcha. So the other thing that I have heard about kind of prepping for chemotherapy, I know we're really emphasizing the chemotherapy here, but we'll move back into our regular scheduled program in just a second. But the other thing I would love to hear about is fasting in association with getting chemotherapy. Can you talk a little bit about that and why and how long and when?
Totally. Yeah. This was data that came out probably about 5 or 6 years ago, and it was really fascinating at the time. And it's something I still have patients do if they're on chemotherapy, if it's possible. And that's go into therapy or chemo in a fasting state. So no food, water, of course, yes, fluids, all of that, but no food, no calories. You really only need about 13 to 14 hours. That's what the research says. I've found anecdotally about 16 is probably better than 13 or 14, but beyond that, it's not really necessary. So that means maybe skip dinner and then go earlier in the morning, or eat an early dinner. So as long as you're in that 13 to 14 hour window, which is pretty easy for most people, especially when you're on chemo and your appetite's probably low, 13 to 14 hours up to 16, and then go in and get your infusion. What they've found is essentially those cancer cells get hungry. They want food because they need sugar to survive. Some can use other alternative fuel sources. I'll kind of push that to the side for now, but most of them rely on sugar. And so if the blood sugar is getting a little bit lower, they're hungry, they're ready, they're primed and ready. So when that chemotherapy comes in, they're just like, and suck it all up and more die. So they end up, there is a better response rate. Same thing is actually true of, that's partly how the high dose vitamin C works as well, because vitamin C, the molecule of vitamin C, looks very similar to glucose. And so they suck up that high dose vitamin C thinking, oh, this is a fuel source. And then again, it releases all this hydrogen peroxide, and they can't detox it. They can't reduce it, reduce it. And so it kills them. So very similar. So definitely fasting there. And we do have data that it does improve a chemotherapy response and also reduces side effects. So I will have people bring like a relatively low carb, high protein meal with them, like lentils with veggies, or, a nice soup, like something nourishing. Again, doesn't have to be no carb, but lowish carb, high protein, to eat about halfway through, because it's really just that initial flooding in of the chemotherapy that's going to have the biggest effect. So, and I don't want somebody to be getting really sick because they get really hungry. So about halfway through, eat, and you're good to go. People can still have black coffee, black tea, things like that in the morning. But I've actually had patients completely change their entire chemotherapy schedule just because they're like, well, I normally go in at 4 p.m. and that's going to be really hard. So I'm like, well, see if you can switch to the morning, or very early afternoon. It depends on how much they can fast. And it definitely, it's a pretty important and easy step to take.
Okay. So we're talking about kind of the conventional care already. We're talking about some integrative ways to, amend that program. We've talked about surgery. We've talked about radiation. We've talked about chemotherapy. What else?
The big new player on the block over the past few years is immunotherapy. And this is really revolutionizing conventional oncology right now, because it's a novel approach, and it's essentially recruiting our own immune systems to identify the cancer cells, or it's modulating those cancer cells in such a way that all that hiding, all of the sort of concealing it's doing to evade the immune system, you can think of it as like opening up and exposing a bunch of antigens that were no longer, or that were previously not exposed, so that the immune system says, oh, hey, that's the lock that I need, or the key, that's the key that goes into me. And then they lock on. And so it's actually the immune system that does the job. And there's the main one that's being used, and the biggest one that's been researched is Keytruda or pembrolizumab, but that can be used alone or in combination with a variety of other immunotherapies. And now the new research is showing, which I find fascinating, is showing that low dose like metronomic chemotherapy with immunotherapy actually leads to the best results, because the chemotherapy causes these molecular changes in those cells and kind of changes the antigens as well, or the milieu around the tumor, and exposes enough of those antigens that the immunotherapy can then kind of target the immune system to do what it needs to do. So that's something that's being implemented in a lot of places as well, or by various medical oncologists. Certain cancer types, it's now the standard of care to use immunotherapy, like melanoma, metastatic melanoma. It's standard of care to use immunotherapy, but often at this stage, it's being used when somebody stops responding to chemo, and or like a terminal, what we would call a terminal, or an advanced stage 3 or 4 cancer patient, when they're on chemotherapy as maintenance and the cancer still progresses, and they'll say, okay, we're going to do this immunotherapy instead because now your insurance will pay for it, and so we'll try it. But what the problem is with that is that it's relying on the immune system to work. And at this point, the immune system is trashed by all the immunotherapy, or by all the chemotherapy. It's been so depleted that, and it's under so much strain and stress, that it's hard for it to kind of do the work it needs to do. So my hope is to see in the next 5 or 10 years that immunotherapy will be first line, or immunotherapy plus low dose chemotherapy, because I also have just seen, again, countless times that people tolerate low dose chemotherapy so much easier than these big blasts every 3 weeks, and they're just laid out. So I think that approach, one of those 2 approaches, depending on the cancer types, is probably going to be what we see as first line therapy for advanced cancers moving forward.
Okay, so we've talked about kind of the conventional care approach, some combination of surgery, radiation, chemotherapy, and immunotherapy. Any other treatments you want to mention kind of from the conventional side up front?
Yeah, good question. I think those are the big ones. Yeah, that's it. Those are from the conventional world. Those are pretty much the biggest treatments.
All right. So let's move on to what is integrative oncology. How is it different?
Yep, another great question. So integrative oncology is, you can think of it as support for the whole person and for the treatments to work better in a person who has cancer. So it's not, now I won't say we don't directly treat cancer, because that's not accurate, but we're not, medical oncologists. I don't administer chemotherapy. I don't administer immunotherapy. I certainly have no training in administering radiation. I'm not a radiation oncologist, I'm not a surgeon. But what I do is work in a way alongside those folks to, again, for my patient, increase the treatment effect, make the treatments work. Like if they're going to do chemotherapy, I want them to do it right so that we're not antidoting how it works. Same with immunotherapy. I don't want to give somebody something that's going to blunt the effects of the immunotherapy. So I want to give them things that are going to make it work better. So working alongside, or same with surgery, if somebody has to get surgery, giving them plenty of support before and after to make sure that their body heals appropriately and that it doesn't spread the cancer by kind of shaking up the tumor bed in the surgery. So there's a lot of different things. So it's essentially supporting the whole person, the whole treatment, and then of course always looking at the foundations. So again, like how do we get here? How is this, like, is it genetics? Is it environmental toxins? Is it chronic infections? What's dragging the immune system down? Why didn't it kick in? Why did things spiral out of control? Is it what factors in somebody's life can be modified? What can we do just in their whole life to, again, prevent this from happening? A lot of conversations about diet, because there's definitely people who have metabolic syndrome and high blood sugar and atherosclerotic cardiovascular disease, things like that. They're going to be obesity. a lot higher incidence of cancer in those populations. So we, not that we necessarily have to focus on weight loss, but how's the metabolism? How is somebody's cellular metabolism? Is their blood sugar high? Are their lipids high? Do they have some sort of, obviously, some metabolic dysfunction happening? Do they have a mitochondrial issue? And because that all impacts cancer as well. So really looking at how their immune system is, how their stress levels are. I've asked probably 200 patients, why do you think you got this cancer at this time in your life? And probably if I just say 200, it's probably been about 180 or 190 have said stress. So I don't, it's a big deal. And is that true? We don't know. It's just their intuitive sense, but I trust that they know their life and they know their body. So stress is a huge component, and it also inhibits our immune system. It dampens our immune response. So, and causes high blood sugar, things like that. So it's just a double whammy with prolonged stress hormones. And then other things, there are a ton of different molecular targets that we can target through botanicals. So different drivers of cancer. The biggest one is like TP53, P53. Curcumin there's no drugs that target P53, and almost 100% of cancers have an inherited or a somatic mutation of P53, which is allowing it to replicate out of control. And curcumin will downregulate that. Again, no drugs that we know of right now will target P53, but curcumin does. So there's infinite different things like that. APC, berber, there's all different sorts of sort of in the cancer pathways, different molecular targets, Notch, just so many different ones that botanicals will downregulate. Now, does that mean that somebody can take high doses of these herbs and not need another treatment or not need to get surgery? No. But it means that, kind of like thinking about with the chemotherapy, we're just trying to clear the space, carpet bomb everything, kind of hope that we get any stragglers. We can do that with natural medicines too, absolutely. And there's a lot, and it's nuanced. It's not like, oh, everybody should have curcumin, like not necessarily. And because a lot of these botanicals are also they're antioxidants, so that's where it becomes a very nuanced conversation about.
Yeah, exactly. Because that's the conversation I am excited. Like, let's dive into that a little bit. Like, if you're looking at people's diet, lifestyle, mental health, certainly we can talk about how inflammation has gotten people to this cancer state. But how do we, if you're going to do like correct inflammation in diet or in lifestyle or in the mind, how are you not just creating an anti-inflammatory state that's going to counteract a chemotherapy or a high dose vitamin C treatment?
Yeah, it's a good question. And it's more about sort of this sequence of events and also how I'm going to treat a person or work with a person when they're on active therapy, like chemotherapy, versus once they're done, they've finished a cycle, or they're presumed their scans show NED. Right now you're clear. So come back in 3 months or 6 months. No evidence of disease. So NED is like pre-remission. It means for the first 2 years after somebody's has clear scans, and at this point also no sign in the blood that there's still circulating tumor DNA or RNA. At that point, they're presumed like you're good, but there's still high risk of recurrence. And so after 2 years, 2 years or 5 years, it kind of depends on cancer type, you would say they're actually in true remission, and assume that it's not going to come back again. That's kind of being dismantled at this point, because we're seeing these tumors or cancers coming back way later, but for the most part, that's true. The risk of recurrence goes way down. So if somebody's in that no evidence of disease or full remission state, then we can go haywire with tons of antioxidants, but and all the things we want to do. But yeah, so it's really only radiation too. Although, see, it's very complicated, because with radiation, curcumin sensitizes the cancer cells to the effects of radiation, so it makes them more likely to die, and it protects the healthy cells from the effects of radiation, meaning they're likely to not have as much damage. So when somebody's on on a radiation regimen, I want them to be taking high dose curcumin, even though radiation also causes oxidative damage. But we have tons of data that curcumin will protect the body. So again, it gets very nuanced in when we use antioxidants and when we don't. Another example would be for a patient on with pancreatic cancer. We have a protocol called the Berkson protocol, and it involves alpha lipoic acid as an IV, a high dose of alpha lipoic acid as an IV. And the response rate is incredible. It's also an antioxidant. They may be on gemcitabine, or they may be on oxaliplatin, or they may be on some other chemotherapy regimen, FOLFOX, but it doesn't seem to antidote anything. It makes it work better. So, but there's a specific protocol. And again, there's been a lot of research into it. So it's not 100% no antioxidants, because I think this is also a misnomer. People, if you eat fruits and vegetables, you're getting antioxidants. They don't tell you don't eat any fruits and vegetables, don't eat any plants. Like you can't have any. No, we all have to have some degree of antioxidants. You just don't want super physiological doses of antioxidants, again, unless somebody knows what they're doing. And also, yes, herbs are definitely antioxidant, but it's still not like taking a high dose of vitamin E or a high dose of vitamin C or a lot of glutathione. Like those are definitely really strong antioxidants versus curcumin also has antioxidant properties, but it's more complex. It's not like
and that high dose of vitamin C, dose of vitamin C as an antioxidant would be, say, below the 20 grams. Right. Above the 500 we might take, but somewhere between 500 milligrams and 2,000 or 20,000 milligrams, which would be 20 grams, would be considered like a low dose of vitamin C and an antioxidant. And then above that would be
and only anytime, like any oral vitamin C is low dose, because you cannot physically take 25 grams of vitamin C orally, nor 50. You will not make it out of the bathroom. You will be in really rough shape. So anytime you're taking oral, so basically oral vitamin C supplements as like a solo. Again, I wouldn't ever tell a patient, don't have citrus fruits, don't have, unless they had an allergy or something, but don't have whatever fruit, or like broccoli because it has vitamin C. You can't have that. It's an antioxidant. No, we want people to be eating a high phytonutrient diet, and there are antioxidants and all of that. So, but it really is so super physiological. Like if somebody were taking 1,000 milligrams of vitamin C 4 times a day and it didn't cause them diarrhea for whatever reason, I would tell them immediately to stop. Don't do, if they were on chemotherapy, I'd say don't do that. Don't that. And I actually had to tell a patient that just yesterday. She was inquiring about taking vitamin C to support her immune system, and I said stick with food sources.
So let's talk a little bit about the integrative oncology program that you run at Neuroveda Health. Talk to us about first about like, how do patients come to you and what do they come for? Like at what stage in this process?
They can come at any stage. So I've seen patients who just have a strong family history of cancer and don't want to get it because they know they're probably likely to get it based on their genes. And so it can include genetic testing. Like let's do some genetic testing and see, do you have the genes in question? Because if you do, I want you to see a genetic counselor. And also let's talk about overnight fasting, keeping your blood sugar under control, supporting your immune system, stress reduction, healthy relationships, healthy food, eating what's right for your body type, all of that, so that we can minimize the amount of the inflammatory tone of the body, so that hopefully, if nothing else, it prolongs the amount of time before those genes will turn on. Because of course you can have the genes, but epigenetics is turning those on. And so if the environment isn't conducive to turn on those genes, then maybe they won't get it, or maybe they would have gotten it at age 35 and now they don't get it till 85, like we don't know. So primary prevention, definitely that's the ideal, of course. Sometimes people see me right after a first diagnosis and they're really freaked out, and maybe it's a breast tumor and it's really small and it's not that the oncologist isn't concerned. It's not a big deal, but they're going through it emotionally and just really facing their own mortality. And even though they're not, because it's not a lethal diagnosis, to them it is. It feels like it. And so people will have the amount of stress that people go through and emotional upheaval at a cancer diagnosis is tremendous. It's a huge burden. That's actually part of integrative oncology too, is let's treat your spirit, your mind, your heart. Like, let's talk about how you're doing. This is hard. Like, how's it going? And what can I do to support you? So that's because it's a whole person approach. But so then of course, if they're just going to get surgery, then I just give them some pre-surgical protocols, go into the diet lifestyle, probably give them some botanicals after the surgery to make sure that we just kind of keep it away. If it's estrogen mediated, things to support estrogen detox, or maybe other botanicals that are anti-cancer, just broad spectrum anti-cancer, just to support, prevent recurrence, things like that. Again, focusing on metabolism or the energy pathways and the immune system. Those are always a huge focus as well. So, and there can be other testing as well, but I would say that's in an early stage, it's pretty clear cut. Where things get more interesting, but also trickier, is in those stage 3 or 4. Stage 3, I think, is kind of ideal because it hasn't spread far enough that like it's for sure a done deal here, but so we have a lot more, but people are also really scared. And so we have a lot more room to go out on limbs and try things in that other people wouldn't want to try, because they'd be like, well, I'll just be fine, or I don't want to kind of spend that money, or whatever it is. They're like, the oncologist is telling me it's stage 3, which means I'm terminal eventually, but they're not going to do anything until they find it in another place in my body. Let's hit it with everything we've got. Like, let's go for it, full stop. And so stage 3, I think, and not many people are caught in stage 3 either. So it's a more unique stage. Stage 4, once it's metastatic, they're likely going to be on some sort of systemic therapy. And so that's where I'm going to be really cautious with any kind of interactions. And really working alongside the medical oncologist. And, I think I can't remember. I have to pull up this paper. I meant to do it before this and I forgot, but there are outcomes research that shows that people who get integrative oncology alongside their conventional care do better than any other group. So the people who get natural care only and don't do any conventional oncology did the worst. Then people who just did just medical oncology, no foundational stuff, no integrative medicine. And by far the group that had the longest survival and the best quality of life were people who did both together. And so it's not, yeah, exactly. And that's what we are, right? Both of us, we're not either or. We're trying to bring everybody together. Like, we're trying to bridge the gap. And I tell it to my patients, like, it's not me or them, like, I want everything to be very transparent and very clear. I want your medical oncologist to know my name. I want them to know what I'm doing. I want them to read my chart notes, read my bibliography, educate themselves on the things we're doing. This isn't trying to be like us playing against each other. And that's where the best effects are, is when the medical oncologist is on board. And because it's not always the case, although in Seattle, we're pretty lucky. So
just to re-emphasize, like, what we are not talking about here is alternative medicine. We really are talking about integrative medicine. And so one of the things that I've always been impressed about your practice is how comfortable you are working with surgeons and radiation oncologists and conventional medical practitioners. Your practice has always been incredibly evidence-based. And so that is a priority. So this is not a situation where you're saying, I was going to say F you to the medical system. We're going to do it this all natural way. This is really like, we want best outcomes for patients. And so we want to use all of the tools that are currently available. So tools from ancient medicine, tools from ketamine assisted psychotherapy, from psychedelic space, tools from diet and lifestyle in the mind, tools from integrative oncology, tools from specifically emphasizing tools that have a research backing. So I really have always appreciated that collaborative nature of your practice.
Yeah, it's definitely, I was trained in it. I mean, and it's also because, like I said, I just have seen time and time again, that's how patients get the best outcome. And part of my job is really to educate people. I've had a lot of patients who won't do the conventional care because they're so fused to their belief system. And part of my job is to try to, ironically, think, oh, the naturopath is probably gonna be like, yeah, that's great. And I'm like, let's talk about this again. Like, let's talk about what it looks like to die of metastatic cancer, because that's what will happen if you don't get this tiny 2 millimeter tumor cut out now. Like, this is what will happen. And people can listen or not. I'm not the type of provider that I won't work with them if they're refusing conventional care, but they have to have an oncologist. They have to be at least getting scans and labs with that oncologist. And then I have to do counseling every single time. All right, you ready to do it? All right, you ready to do it? All right, you ready to do it? So, and then if they don't, patient declines in spite of my endless pleas, whatever. So I still will work with patients. Again, that's how I was trained. It was because some naturopathic oncologists won't. They'll just be like, it's too much of a liability. If you don't have an oncologist and if you won't do the treatments, I won't see you. So I will, but people sometimes need time. They need some buy-in. And so I'm just trying to improve the outcomes for them. So yeah, definitely not either or. And they're the best results with both, and sometimes I'm educating medical oncologists, like I'll run liquid biopsies to identify circulating tumor DNA and different molecular targets for conventional FDA approved therapies like immunotherapies. And sometimes it's really surprising. Somebody it looks like they're going to have a great response to something like Keytruda, and the medical oncologist wouldn't have done the test to know that. And so I send everything over, like, this is what I'm recommending. Like, can we get this going? And sometimes they do, sometimes they don't. They normally at least have a conversation. And if they don't think it's appropriate, they say why, or I'll just say, why don't you get a second opinion with this other oncologist that I know? And because I think it's ideal if we can skip some of the non-specific treatments for a more specific treatment, as long as it's indicated.
So patients find you for primary prevention, like strong family history. They don't want to get anything. They come in when they've just been diagnosed and they're looking for partnership and trying to figure out who their care team is going to be, and you're happy to work on the team. Yep. Patients come in when they're stages 3 or 4 for cancer, like they've tried things and things aren't working, or they're not working well enough, or they're having too many side effects.
Yep.
And then I just want to mention, patients come to you after they have finished their care to recover from cancer and cancer treatment. And patients also come to you for that secondary prevention, so that after, they have recovered, but as they're sitting home thinking about they're thinking, I do not want this again. And then they seek out your care. Is that correct?
That's exactly right. Yep. So they could be already in remission, or again in that NED stage, and be still very anxious. There's like a huge amount of existential distress. So maybe they don't have cancer anymore, but they're like, I don't want this to come back. So that's secondary prevention. And I do a lot. That's, again, a right place where we can do a ton of work. But also, something I should mention is that I will also walk with people through the end stages. I mean, of course, I work in oncology. I've lost many patients to cancer. And very often, just through the amount of time they're able to spend with me, the questions they're able to ask, just the space kind of that I hold, and just the relationship that we build together, they feel way more comfortable with me at that point than they generally do their oncologist who sees them for 10 minutes, every few weeks. And so no judgment on them, they're doing their jobs, but it's just kind of natural because we spend more time together. And so often patients are more comfortable opening up to me when they're like, I'm done. I'm done. Or can we talk about when to call it? Can you tell me when to call it? I don't want to push myself too hard, but I know I will. So can you tell me when it's over? And so that can we talk about death with dignity? Can we talk about initiation of hospice? When is it appropriate? And so, just being with them, and then with their family members. That's something else that's very unique about this branch of medicine, is that as a person starts their transition, my communication changes to whoever their primary caregiver was, because they're no longer generally verbal. And so there's a lot of family work, and then also helping them recover after the loss. And also with the existential distress, that's partly where the ketamine assisted psychotherapy comes, or the ketamine therapy. I did outcomes research on ketamine assisted psychotherapy for cancer patients, and outcomes were better, very interestingly. Immune function was better, very interestingly. That's the psychoneuroimmunology. And also just people's sense of in the psychedelic world, we call it dying before you die. So in facing one's own death or having like a mini death through a psychedelic experience or an ego death, people can open up and realize, have some connection to something greater, and realizing the end isn't the end. And I'm ready to face whatever it is that's around the corner. And so whether at any stage, I've done ketamine for people at any stage, and it can be profoundly healing for people facing end of life. Like we could have a whole podcast just on that, because I have some pretty intense stories, but really amazing outcomes with that. Just kind of holding their hand. I always say I'm kind of almost like a death doula in certain ways with my job, and that's good, but that's a natural part of life, and there's no judgment one way or another. I don't think of it as like, oh, we lost this one, or this was a failure, or what did I do, or like, it's their time and it's natural, and we just have to accept it and support people and love them. That's it.
Yeah. Dr. Ladd, my Ayurvedic teacher, just ran a program called The Art of Dying with Bliss. So, one of the things that supports us throughout our life is our neuroplasticity, is the idea that we stay current with our environment, that we are continuing to see every sunset as a new sunset, every sunrise as a new sunrise. And so having that ongoing neuroplasticity and recognizing that transition out of this life and back into that ocean of consciousness is a further adventure. So we want that neuroplasticity as much as we can have awareness and full consciousness. Sometimes it's not possible. The pain is too great. We have patients using morphine or methadone or ketamine or fentanyl patches, things that may dull consciousness. But the idea is, to the degree that that awareness and presence is possible, we want that through the last breath.
Mm-hmm. Absolutely.
So before that, though, let's talk about patients come in. Can you talk a little bit about the different types of testing that you do? You do some pretty unique oncology testing here.
Mm-hmm. Yeah. So I think the most exciting, I've been using these tests some of them are newer, but in general, what we call liquid biopsies, I've been using them since I was still in school, so probably 7 years. And that's really when they were just coming out. So liquid biopsies it's just a blood test, just like any other blood test, but it's looking for cell-free DNA. And specifically mutated DNA or mutated genes that are or markers that show it's been shed from a cancer cell. Like, this is not a normal cell. These are cell-free, because you really shouldn't have cell-free DNA in your body anyway. That means that there's necrosis happening. So what is interesting is that's where we can get a huge amount of information about what cancer what cancer treatment is currently most indicated for a person, because cancer mutates. I said it's spiraling out of control, and it has really no stopgap measures at this point. So it makes a lot of mistakes, and it just keeps replicating, it keeps acquiring mutations. And so if we have somebody's original biopsy and we know what molecular targets were on their tissue, then we can compare it over time to what's in the blood. And this is mainly in those advanced cancers, because theoretically there should be no cell-free DNA in early cancers because it hasn't gotten into the blood. Now, it's also kind of changing, but I'll leave that for now because it's an emerging research area. But so these liquid biopsies, some of them do both DNA and RNA. Most of them just do DNA, but doing them serially, and really comparing, because you can see as the mutations go up or the mutational burden goes up, you can see the cancer's growing and it's not responding. And as it goes down, okay, they are responding. Things are getting better. There's fewer mutations, there's less amplification. So it's really good to track over time and to track treatment response. And there's a variety of these, but yeah, I have my preference.
And you would gauge how often you're doing your monitoring, like based on the type of cancer?
Not necessarily, based on their treatment, and then based like what their active treatment is. And also if they're in that early NED stage where we're not sure if they're in that early. So you can think of it, honestly, they really should go along with scans. So if somebody's getting PET CTs or even just CT scans like every 3 months, then just do the liquid biopsy at the same time. And that also gives us an idea as we see the pictures or we see the reports of the pictures and we see what's happening with the amplification of these molecular targets. We can see, okay, are these concordant? And they pretty much always are. So as the tumor mutational burden goes up, we're probably seeing it explode in areas of the body. As it goes down, probably very low signal on the imaging. So that's how I normally do it. And then same like with their, in that first 1 to 2 years, people generally have quarterly scans. So quarterly liquid biopsy. And then after that, probably spread it out to 6 months, just like they do with their scans, then spread it out to annually, just like they do with their scans. So it can really follow that trajectory for the most part. And again, I don't use these typically in early stage cancers. It's typically just in the stage 3-4 populations.
And some of these examples are like Garden or Signatera or Polaris.
Exactly. Right? Yeah. And there's, well, yeah. So the Garden, Signatera, there's a bunch of new ones coming out. There's also LabCorp has a number of new ones as well. Their oncology profile has really exploded. So they have some good testing as well now. OmniSeq is one, and they have a liquid biopsy, but Foundation One is another one for liquid tumors or liquid cancers. Prolaris is really interesting because anybody in medicine knows that PSA is not a super great marker for prostate cancer.
PSA meaning prostate?
PSA meaning prostate specific antigen. Is not a great marker for cancer. It can be, but it's often not. And
that, but it's the one we use, right?
It's the one we use. It's the one we use, but it's that even the Gleason score. So if somebody gets a biopsy of their prostate and they get this Gleason score that's based on essentially how active the cancer is, and it's this complex algorithm, but it doesn't predict things as well as it should. It really just doesn't predict things like how aggressive it is, or if it's something we need to be concerned about or not, because plenty of men have benign prostate tumors or benign prostatic hyperplasia or cancer, but it is likely to never grow. It's just kind of there. And that definitely does happen in the prostate and the breast, especially in very older populations. But this Prolaris is really looking at those mitotic spindles. So like on a physical plane, looking at those cells and saying, how rapidly are they turning over? Because if the cells are turning over really rapidly, we're in trouble. If they're not, if it's very indolent and you can barely even see the spindles, it's barely dividing. Why do we care? So it's much more specific. And that one came out a few years ago. And I don't know why I just don't see a lot of prostate cancer patients, but what I do, that is my go-to because it's just such a better test.
Interesting. Fascinating.
Yeah. Okay, so the only other testing I would mention is we do natural killer cell function on most cancer patients. And that's looking at how, adequate your anti-cancer immune system, your first line of anti-cancer immunity is doing. If your NK cell function is very low, it's not your count of NK cells, because you can have the highest count in the world of NK cells, but if they're not doing their job, it doesn't matter. They're just crowding out the space. So it's really looking at their activity. And if it's low, we want to boost that way up because the immune system is not glomming onto those cells the way we need it to. So the natural killer cell function test it's a LabCorp test, but it's a very specialized test. It's kind of a pain, but gives a lot of very valuable information. So that's another special test that we do. And sometimes looking at methylation or MTHFR or chronic viral burden, just viruses, because that's a big deal. Certain viruses can cause cancers, or at best, they just drag down the immune system so that it's distracted when a cancer does arise.
Okay, so people come in, you start with all this testing, and then you're going to put together a treatment plan for folks. And when you're putting together your treatment plan, we could talk about treatment plans for probably 3 days. We could probably do 36 hours of podcasting about treatment plans for cancers. So, just to know that certainly there's diet, there's lifestyle, there's particular cancer treatments. Can you talk a little bit about kind of the metabolic approach to cancer treatment?
Yeah, absolutely. I'm glad you brought this up because I was thinking about it in the conversation about stage 4 too, because that's generally the time that I'll use this particular approach. So I already said I look at the metabolism, how's somebody's blood sugar or lipids, like is their cellular metabolism working optimally? If it's not, we want to tweak that. If it's not, they would be a great candidate for this metabolic approach to cancer. It's based on the Care Oncology protocol out of the UK, actually. And these researchers and oncologists found that you can target various aspects of the cell cycle using off-label drugs with much lower toxicity than something like chemotherapy. So usually there is at least one antibiotic and a dewormer or an antiparasitic, something to bring an anti-diabetic, basically brings down blood sugar, and then a medication to bring down lipids. And generally it's those 4. Those are the 4 that they use. And the dosing and methodology is all a little bit different, and routes and all that. But by doing that, the idea is you can halt all the various aspects of the cell cycle and stop growth. Now, you still have to support the immune system and have something to come in, because even if the cancer cells stop replicating, they still got to go. So there's that part. I've also found some people, like very thin people or people who don't have metabolic dysfunction, don't do great. You don't feel great when their blood sugar is tanked and their cholesterol is tanked, and they're on these heavy duty antibiotics and antiparasitics. So not everybody tolerates it, and not everybody responds to it either. But it's one of the things I'll use if not, basically nothing, they've run out of options, nothing else is working, or I'll use it earlier if their metabolism is very clearly really damaged, and that's the main driver of their issue. Like I can tell, then I'll say, well, you have, like a couple of individual, you have excess, there's excess. So we see the excess, you're probably not going to notice a thing by taking these. And, we can bill it to your insurance. It's not a high cost. There's nothing, like we can just try it. And it doesn't interact with anything. So that is one of the approaches using these repurposed drugs. We can do kind of natural alternatives to the repurposed drugs too, because there are, of course, supplements that reduce cholesterol and that reduce blood sugar and have very similar mechanisms, but it's never going to be quite the same. And we, of course, don't have evidence. That's just like extrapolation of the current data. But it is an option because there are people who don't want to do the repurposed drugs. But that's what, So metabolic approach to cancer is, there's also, discussions about, for example, the ketogenic diet in glioblastoma multiforme. Like that's a high grade recommendation for me. I generally tell people, if you're at all able to do it, do it. And that's because of the evidence. When I first heard about it, I was like, I don't think that's real, but it is. So for that, but a lot of people will come in and they'll have stage 2 or stage 1 breast cancer, and they'll be like, I was told that I should be on a keto diet. I'm like, are you getting radiation? No. Don't worry, is your blood sugar high? No, don't worry about it. That's not the time for keto. But so it very much depends, but I would consider that also kind of a metabolic approach, looking at, again, what's feeding the person and what's feeding the cancer, and what do we need to tweak, whether it's diet, medications, supplements, something to get their metabolism working better, because it's definitely a big player in the whole oncogenesis, we can say.
Mm-hmm. And so let's dive just a little, we're going to close here soon, but just, let's talk a little bit about, we've kind of touched on these things about like what triggers cancer. We've talked a little bit about the viruses, which we know can trigger cancer, like HPV, human papillomavirus, can absolutely trigger cervical cancer. And that's not the only one. Can you talk a little bit about what happens to the immune system during an episode of cancer or after an episode of cancer, and how does cancer interact with the rest of the immune system? Like, what about autoimmune disease? 1 in 9 women will have an autoimmune condition. So what's the relationship between the immune system as an umbrella and then the individual things that can kind of go sideways within it, including cancer, including autoimmune disease?
Yeah. So anybody with an autoimmune illness, especially specific kinds of autoimmune illnesses, but in general, people with autoimmunity have a higher risk of developing cancer. And again, we can go back to the Ayurveda conversation about the cells have lost their intelligence and their ego, their sense of who they are and what their role is. And now they're attacking self instead of attacking other. And so it's obviously, I said it's very similar with cancer, the cancer cells. So there's this loss of prana, there's this loss of vitality and life force, and also tejas, their consciousness, and too much fire. There's kind of like burning, tejas burning ojas, fire burning out our immune system, our immune reserve. So that's kind of the Ayurvedic approach to autoimmunity. But either way, there's that loss of that intelligence. And so the other thing that happens is chronic inflammation. So unless it's an autoimmune illness that's very well controlled, there's likely out of control inflammation. And out of control inflammation, they still don't really understand why, but they know that the researchers know that high amounts of inflammation predisposes a person to developing cancer. It's probably just because the immune system, again, is so ramped up and it's not focusing where it should focus. It's focusing on self, or it's focusing on viruses. It's just tied up. And so when a tumor, a cancer cell arises, it's like, we don't care about you. We're over here. We're attacking this thing. So that's probably part of it. Also, just inflammation in general is hard on the entire system, on the entire body. So yeah, but so that's where it is complicated, is that, everybody's like, I want to boost my immune system. I'm like, well, do you really want to boost your immune system? Like if you just finished chemo, yeah, you do want to boost your immune system. If you have severe progressive Crohn's, you don't want to boost your immune system. You need to dampen that immune response. You need to calm that down because you're at risk. Crohn's is something that increases a person's risk of small bowel and colon cancer. So we need to, and again, that's that chronic inflammation. Any tissue that has chronic inflammation is predisposed to developing cancer big time. And that just makes sense. It's kind of slowly destroying that tissue and more cellular turnover, more room for error. So definitely that would be part of the primary prevention conversation too, is let's look at your inflammatory markers. Let's look at some immune markers, make sure there's no hiding autoimmunity, make sure your inflammation markers are low. And if all that's good, like I'll feel comfortable. And I will do a deeper dive into the immune system for sure. If somebody has a really strong family history, I'll run that NK cell function. Well, you don't have cancer, but I want to make sure your anti-cancer immune system is working well. And also, like clinically, I have seen the people who have the highest NK cell function at baseline, for the most part, with rare exception, if any, I've seen not have recurrences. And the people whose are very low, or who need a lot of things to keep it high, things often either come back or don't go away. So there's definitely, and of course, this is all research-based, but just clinically working with people and doing this test a lot, there's definitely something to it. So if somebody does have a strong family history, I'll look at that. Like, let's make sure your NK cell function, or look at a T cell profile or something like that. Like, make sure that the immune system, in a much more granular way than most doctors do, I'll like really do a deep dive into that immune system, cytokines, things like that.
Awesome. Cancer recovery. After cancer. Yeah.
Yeah. I mean, I think this is where, of course, like I said, all the lifestyle, all the diet, all the, get them on a good program of botanicals, just depending on what their issue is. If they have metabolic issues, make sure those are kept in check, immune health, all of that, gut health, all that. But I think the biggest thing with cancer recovery is the mind and the heart and the spirit, because it's, like I said, it's very easy for me to look at a patient and they have this tiny 2 millimeter tumor in their breast. And I'm like, oh, this is no big deal. I just get it cut off, no big deal. But that's not how it feels to people. It's very distressing. And so I think that really focusing on improving relationships, improving sleep, improving relationship with self, acceptance of self, going into the trauma. It's important to note that people with 4 or more ACEs or adverse childhood events have a much higher risk of developing cancer later in life. And actually, I was meeting with a therapist at our open house last week, and she said she was working in hospice, and she got into being a social worker and a counselor because she was noticing that all of her terminal cancer patients had severe trauma. And so she started to pay attention to that and said, I think I need to work in the trauma. I think I need to work in trauma. Like, this is what I need to do because like, that's what's getting people here. So really diving into that, and whether, again, that's the ketamine assisted therapy or whether that's other trauma or systems work, like it doesn't necessarily matter. Energy work, body work, whatever will get somebody to, move it and move through it, identify it. It's a huge aspect of the whole journey, especially in the recovery, is that mind-body connection and the stress, the relationships, the self-love. Those are really important foundations that are a big part of the recovery from cancer journey.
And then also kind of like your digestive tract, if you've had nausea and vomiting,
of course,
tissue, like your tissue, getting your tissue juiced up again.
Of course, exactly. Like anything that's been damaged, anything that's been impaired. Like I said, with both radiation and chemotherapy, it's about a year before people's immune systems bounce back. So what can we do to support your immune system for that time, not get sick? All of this. And again, of course, any tissues that have been destroyed, like irradiated or something like that. And then prevention of future cancers as well. And we may or may not do IV therapy at that point. Again, it depends. Nutritional stuff. The other things that we didn't get into too much, they both, in my mind, go with botanicals, as medical cannabis and medicinal mushrooms. So those are all kind of in the blanket statement of botanicals, but all of those things can be used at any stage of the journey, whether it's recovery, active treatment, or primary prevention as well.
And those are interventions you use commonly and you're comfortable with and experienced with and confident in your practice?
Yes, very much. Both of them. Lots of experience with both of them. So yeah, I use them to a very granular degree. So it's not just like, all the different mushrooms and different dosings and what they're best for. And because they're not all alike. And definitely with cannabis, all the ratios and all the forms and how do you take it in? What dose do you need? When can't you use it? When should you use it? Even just, I'm really anxious, like whatever it is. It can be just like palliative to help with symptoms or pain. Obviously, if somebody has really bad pain and they're trying to avoid opiates or opioids. So yeah, it's a whole world of its own, but they're definitely a big part of integrative oncology.
Great.
What a show today. Holy cow. Okay, well, we've been through it, and we love that you've joined us today to discuss how to make our whole world medicine. We rise or fall together and are committed to sharing knowledge and insight that empower us and our communities towards greater health. Thank you for listening to the Neuroveda podcast for complex health. We'll see you next time.